So today we are here to talk to you about the steps of the kidney or the renal transplant. Okay, so that's what we are going to discuss today. Okay, now the first thing what you need to understand is the first step of performing any kidney transplant is having a donor kidney. Okay, now what kind of donors are available? We have either a live donor and or we have a cadaveric donor. Okay, so live donor is something which is very commonly done in India. Okay, as I told you that in India, the cadaveric donor is not that what you call as established. Cadaveric program is not that established. What we have immensely established is the what you call as a live donor program. Okay, right? Now, if at all there is a live donor, it means that any living person who is voluntarily willing to donate one of their kidney to the recipient, either we can take that particular kidney via the open route or we can take it via the laparoscopic route. Okay. Now, at many places, even today, they perform an open donor surgery, but like at good institutes, at the places where the transplant numbers are higher, and ideally, we should get it done by the laparoscopic route because already those particular people are doing the act of generosity. And if at all we do it, do the nephrectomy, if at all we do by the laparoscopic route, minimal invasive route, that is definitely going to be better. So that is what is going to be better because the post-op recovery and the comorbidities and everything will be much, much, much lesser. Okay, so yeah, that's what it is. Cadaveric is like obviously that's to open only after the person is declared brain dead, and then we kind of do the retrieval of all the organs, and kidney is one of them. That's fine. Now, after we have gotten a kidney, what we do is something which is called as the bench dissection. Now, what do you understand by a bench dissection? So surrounding the kidney, there is a fat. We have a lot of fibrous tissue and everything. So what we want is in the bench dissection, we want to delineate where the artery is. We want to delineate where the vein is, and we want to kind of dissect the area surrounding the artery and the vein. That is what you basically want to do in the bench dissection. I understand my point. So in the bench dissection, I'll show you the video. You'll understanding it in a bit much better manner. So once we get the kidney, we want to anastomose the artery and the vein, right? So we want to kind of free that artery and the vein from the surrounding fibrous tissue. First thing. Second thing is whatever the fat is there on the kidney, we want to take it off because we don't want to put that particular fat in the recipient. Okay, so that is what is called as a bench dissection. And then we have to perfuse that particular kidney. Okay, we have to perfuse that particular kidney by there are various solutions which we can kind of use in order to perfuse that particular kidney. But yes, we have to perfuse that particular kidney because whatever the blood and everything it was there, we have to kind of get it washed out. Okay, so we have to kind of perfuse that particular kidney. I'll show you like in the video what exactly I'm talking about. Then after that, once you have done the bench dissection and everything, now we have it's time to kind of put this particular kidney into the recipient. Okay, so we can either perform an open transplant or it can be a robotic transplant. Robotic transplant is done at very few places. In India, it is done at around 4-5 places. Our discussion, we will restrict to the open kidney transplant. Okay, so these are the basic steps of the kidney transplant. I'll talk to them about in detail. So kidney transplant can be allograft or it can be heterotopic. Okay, so okay, obviously kidney transplant is allograft. It means that we are taking the kidney from the same species. Okay, only the humans can develop can give the kidney to each other. So it is an allograft and it is heterotopic. What do you understand by heterotopic? Our normal kidneys are basically present in the flank. So we don't place the transplanted kidney in the flank. Where do we place it? We place it mainly in the iliac fossa. Okay, so we kind of place it in the iliac fossa. So that is why, because we are not placing the transplanted organ at the normal or the original position, we are placing it at some other place. That is why it is an heterotopic transplant. Okay, so allograft and heterotopic transplant. Now, where is the kidney placed in the renal transplant? As I told you, in the iliac fossa, usually on the right side. Okay, usually we place it on the right side. Now, incision in the renal transplant and preparation of the bed. So what happens is that we have to give a incision. So it is described as a hockey stick incision. Okay, so what we basically give is a hockey stick incision. Okay, so we give a hockey stick incision, then we kind of enter into the abdomen. We have to do things in the retroperitoneum. We should not open the peritoneum. Okay, so we have to kind of do the dissection or whatever the separation of everything in the retroperitoneum. While we are doing this particular dissection in the retroperitoneum, we reach to the renal art, we reach to the veins and the artery. So which vein and the artery? So we reach to the iliac vessels, external iliac and the internal iliac. So we reach to the iliac vessels, and then what we do is we kind of take the lymph nodes, or we kind of prepare those particular vessels. Okay, with the like whatever the tissue is surrounding those particular vessels, we cut and we kind of prepare that particular bed. Okay, so again, it will be much more clear when I show you the video, but just try to understand what we are doing. We have given that particular acoustic incision. We are restricting ourselves to the retroperitoneum. We have retracted the peritoneum anteriorly. Now we find that there is a iliac vessel. So surrounding the iliac vessels, there are lymph nodes. Okay, so it's like a fat. Obviously, we don't see the lymph nodes per se, but there is some periarterial tissue. What we have to do is, sorry, what we have to do is we have to kind of ligate that particular tissue, and we have to cut that tissue so that the artery is kind of like becoming naked. Okay, so we're basically exposing the artery. Okay, that is what you're basically doing. Okay, I'll show you. I'll show you the video. Just give me a minute. Okay, right. Okay, so we do that now. What we have is we have two arteries. We have external iliac artery and we have an internal iliac artery. Now, if I ask you, forget about the kidney transplant. If I generally ask you, which of these arteries, external iliac or the internal iliac, which of these arteries you can ligate? So we can ligate the internal iliac artery. Internal iliac artery is something which we can ligate safely. Okay, right. Because the other internal iliac artery is there, that's fine. Now, external iliac artery, obviously we cannot ligate. So it's a logical thing that if we use internal iliac artery for the kidney transplant, how are we going to attach the renal artery to that? It will be end to end. Okay, so in the internal iliac artery, we can do end to end anastomosis. In the external iliac artery, what do you do? In the external iliac artery, what you do is end to the side anastomosis. Are you understanding my point? So in the external iliac artery, what you do is end of the renal artery to the side of the external iliac artery. Are you able to understand this point? So this is an external iliac artery. This is an allograft renal artery. So what we do is end of the renal artery to the side of the external iliac artery. So we do end to side anastomosis. In the internal iliac artery, what you do, you have ligated this internal iliac artery, native internal iliac artery, you bring it out, and then what you do is you do an end to end renal artery with the iliac artery anastomosis. Are you understanding my point? So here we are performing an end to end renal with the internal iliac artery anastomosis, and here what we are performing is renal artery to the side of an external iliac artery. Are you understanding my point? Very important. Okay. Very important. This is MCQ. What they ask you is that what is the anastomosis which you do? If we are anastomosing the artery to the external iliac, what we do is end to side anastomosis. If we are anastomosing the artery to the internal iliac, what we do is end to end anastomosis. Okay, so I hope you have understood this particular point. Okay, yeah. Now, what about the venous anastomosis? Venous anastomosis is usually done to the external iliac artery. Okay, it is not done to the internal iliac. It is usually done to the external iliac artery, and that is what is done in the manner of end of the renal vein to the side of the external iliac vein. Are you understanding my point? So this is done between end of the renal vein to the side of an external iliac vein. End to side anastomosis. Okay, so I hope you're able to understand this point. Venous anastomosis is end to side anastomosis. Okay, I hope you have understood this point. Okay. Now, we have done this particular arterial and venous anastomosis. Now it's time to do the ureteric anastomosis. So the technique which is usually followed, or ideally what should be followed in the ureteric anastomosis in the transplant, is called as a modified Leach-Gregor technique. Modified Leach-Gregor technique. Now, what is this modified Leach-Gregor technique is that you are putting in the I'm looking at the urinary bladder. Now, what you do is you start cutting from outside. Okay, you start cutting from outside. You cut the muscle, the trusor muscle, and then you have the mucosa, which is basically popping out. Now, you cut the mucosa at one point. Okay. Now, why is you and me, like in yours and mine, why is the ureter non-refluxing? Like, in other words, the urine inside the urinary bladder, why is it not going to the kidney? Why do we do not have reflux? Because of this intramural length of the ureter. So what happens is that the ureter has a transverse course in the what you call as a urinary bladder. So because of that transverse course, whenever the pressure inside the urinary bladder increases, the ureter is basically compressed anteroposteriorly and the reflux doesn't happen. Are you understanding my point? Right. Now, this is the same thing which we try to, ideally it should be done. Ideally, we should try to create the similar kind of the anastomosis in the kidney transplant patients as well. So what you basically do is you cut through the muscle